For decades, the standard protocol for managing iron deficiency relied on a heavy-handed approach, prescribing oral iron up to 3 times a day and reflexively pushing antihistamines the moment a patient experienced an intravenous infusion reaction. Both the aggressive oral dosing strategy and the antihistamine reflex are physiologically flawed. These inherited clinical habits ignore 2 specific biological mechanisms that dictate how the body actually handles iron: the hepcidin regulatory axis and the KARPA immune pathway. We will examine the exact cellular indicators that dictate when to abandon oral therapy entirely and how to overhaul the management of IV infusion reactions. Aligning clinical practice with these pathways prevents severe gastrointestinal side effects, eliminates the misdiagnosis of anaphylaxis, and secures treatment success where old methods fail. To understand oral absorption, we start at the mucosal surface. Oral preparations, like ferrous sulfate, must be absorbed by the enterocytes lining the gastrointestinal tract. This cross-section of an enterocyte shows how elemental iron successfully crosses the cellular membrane and enters the systemic bloodstream exclusively via the ferroportin channel. However, a single oral dose of iron triggers an immediate feedback loop. The absorbed iron signals the liver to produce a massive surge of the regulatory hormone hepcidin, which travels back to the enterocyte and physically caps the ferroportin channel. This hepcidin-mediated blockade is a strict temporal constraint. It lasts for approximately 24 hours, during which the absorption door is firmly bolted shut. Consequently, daily or thrice-daily dosing regimens force subsequent pills into a locked physiological system. Because the iron cannot cross into the bloodstream, it remains trapped in the gastrointestinal tract. This residual, unabsorbed iron directly causes the severe gastrointestinal side effects, like nausea and severe constipation, seen in up to 70% of patients. The evidence-based clinical standard is now every other day dosing of oral iron. A 48-hour dosing window allows hepatic hepcidin levels to safely drop, entirely reopening the ferroportin channels at the enterocyte to accept the next dose. Every other day dosing maximizes fractional iron absorption through pure mathematical and physiological efficiency. The reduction in patient discomfort is simply a byproduct of correct cellular timing. Anemia of inflammation presents a completely different environment. It is a disorder of iron distribution, not a lack of iron stores. Chronic inflammatory states, like cancer, chronic kidney disease, or inflammatory bowel disease, trigger the continuous release of cytokines, primarily interleukin-6. This flowchart illustrates how IL-6 stimulates continuous hepatic hepcidin production, bypassing temporary surges. This permanent surge locks down both enterocyte absorption and macrophage release channels. Existing iron is trapped within the reticuloendothelial system. This creates the classic diagnostic lab pattern for anemia of inflammation: low serum iron and low transparent saturation, paired with preserved or elevated ferritin levels. Because the enterocyte is securely locked by this inflammatory cascade, prescribing oral iron to these patients is physiologically futile. It cannot be absorbed. Systemic inflammation creates an absolute barrier at the gut. Repletion requires an immediate shift to an intravenous bypass. Transitioning to IV therapy requires precise algorithmic selection. Intravenous iron formulations are distinct compounds with unique safety profiles. This comparison matrix breaks down the specific constraints of the major formulations. Ferric carboxymaltose, or Injectafer, carries a specific biochemical danger. It induces hypophosphatemia. Physicians must aggressively monitor serum phosphate levels when selecting this formulation, particularly in patients requiring multiple doses. Ferromoxetol, or Ferraheme, introduces a unique diagnostic limitation. Its magnetic properties interfere with MRI imaging for up to 3 months post-infusion. If ferromoxetol is administered, a strict logistical protocol requires proactively notifying radiology departments to prevent misinterpreted scans. Low molecular weight iron dextran maintains a severe black box safety profile due to the risk of true anaphylaxis, mandating a supervised test dose before full administration. Conversely, ferric derisomaltose, or monoferric, offers practical utility for outpatient logistics, allowing for up to 1,000 mg single-dose repletion, reducing clinic visits and improving patient compliance. Safe intravenous iron therapy demands matching the specific molecular and logistical constraints of a formulation directly to the patient's comorbidities. When executing these IV formulations, acute bedside management of infusion reactions must be precise. The most dangerous assumption a physician can make during an infusion is treating a mild to moderate reaction as an IgE-mediated allergy. This diagram of the immune cascade shows the true mechanism. The vast majority of IV iron reactions are CARPA, a complement activation-related pseudoallergy, which bypasses IgE entirely. The historical reflexive habit in many clinics is to immediately push intravenous diphenhydramine to suppress what they assume is a histamine response. Intravenous diphenhydramine induces profound anticholinergic and vasodilatory side effects. The resulting tachycardia, hypotension, and somnolence perfectly mimic the signs of worsening cardiovascular collapse and anaphylaxis. The correct, evidence-based protocol for a CARPA reaction is mechanical. Stop the infusion, wait 15 minutes for the complement cascade to settle, and simply restart the flow at a slower rate. Treating a complement-mediated pseudoallergy with an antihistamine actively confounds the clinical picture, artificially creating the symptoms of shock and risking the dangerous, unnecessary administration of epinephrine. This clinical flowchart synthesizes these physiological rules into a single, actionable algorithm for iron replacement. First, the hepcidin barrier dictates that uncomplicated iron deficiency anemia is managed strictly with every other day oral dosing. Second, any high hepcidin inflammatory or malabsorptive state mandates bypassing the gut with a carefully selected, formulation-specific intravenous iron. Third, infusion reactions require a strict pause and restart protocol, completely omitting antihistamines from the bedside response. Once the correct pathway is initiated, hematologic recovery follows a predictable timeline. An appropriate bone marrow response produces reticulocytosis in 3 to 4 days, followed by a hemoglobin rise of 1 to 2 grams per deciliter by weeks 2 to 4. Achieving hematologic mastery requires us to completely discard these outdated historical habits and instead build repletion strategies based entirely on actual cellular physiology.